This is our January Northeast Ohio Opioid Consortium Education Series event. Today, we're pleased to be joined by Dr. Deetra Hawkins. Dr. Hawkins is a clinical psychologist at the Yale Program for Recovery and Community Health. She has over 2 decades of experience helping individuals, communities, and organizations apply research-based approaches to diversity, equity, and inclusion. We are going to focus today's discussion a little bit from a recovery appreciative approach to recovery systems of care, and we look forward to hearing from Dr. Hawkins. I would also like to share just a little personal scoop on Dr. Hawkins. It's nice to know who you're engaged with. She is a mother, a wife, a Black Catholic, and an ally for all people in recovery. So she is rooted in values of faith, integrity, humility, collaboration, and inclusion. And she loves her work because it helps bring people together to facilitate healing. We are really pleased to have her with us today, and we hope this is just the beginning of an ongoing relationship. Dr. Deetra, I'll turn it over to you. Thank you so much.
Thank you. And thank you for that great introduction and everybody being here and showing up. We're super excited to be with you today and to hopefully have some engaging conversation as well as an opportunity for some Q&A and conversation. So I have a team with me. We'll have a chance for them to say hi and introduce themselves in just a little bit. As many people as are possible, if you are able to be on screen, it always helps us in our process and work to like see who we're working with and who we're communicating with. So all kinds of different things going on. I have a Connecticut number because I still do a lot of work in Connecticut, but I do live in Atlanta. I am going to go ahead and share my slides so that I don't have to tell my team, next slide, next slide. But before we get started, in terms of the content and our flow, really like to invite you all to share what is a hope that you have for today's session. You could add that in the chat. Are you all seeing my screen? Okay, awesome. And if you are not able to be on camera, if you could give me like an emoji, like send me some flowers or something like that, that would be great, just so I know. Thank you. Is it Bridget? Okay. And Sarah, thank you. All right. And my team is going to be looking at what you're saying as a hope for today's session. Sort of did a little bit of a retitling here just to say that we're using an appreciative approach, an appreciative inquiry approach, thinking about medical dominancy to relational recovery. And one of the ways I like to think about this is just how is recovery an antidote to some of the things that often get in the way of people getting well. That is really what my goal is about, is helping us to think about ways that we can do that. Okay, love that, Sarah. Thank you. Yeah, and it's interesting in terms of just thinking about like how we have these conversations, just to branch this out a little bit. I do a lot trying to help people just learn how to create opportunities for brave conversation, and also how to have dialogue with each other, especially in this understanding of like moving toward wellness, And so there's a lot that we can do. And sometimes I think in our healthcare settings, we've gotten away from the reasons that we came into the field to start with, right? That many of us came in because we wanted to be helpful. And some of the things that we were taught to do are not always very helpful. So let's continue. If there are other things that you would say would be helpful or that you're interested in learning, please put that in chat. We are going to have some breakout rooms and we're going to try to be as interactive as we can. Just to say a couple more things about myself, I often like to start off by saying that I am a facilitator more than a trainer. And that is important to me because I'm very interested in helping people change what they do and not change just how they think about things. I have been doing research for a number of years, both quantitative and qualitative. And I think of myself as a recovery advocate and ally. I'm a family member. Um, and very early in my training as a psychologist, really was introduced to the recovery movement through Dr. Tom Kirk and Dr. Arthur Evans in Connecticut. So I also work as an executive coach, especially supporting leaders who are, in these initiatives trying to figure out ways to be well, reduce burnout, right? All of us are dealing with burnout, and also to bring groups together so we're not working in silos. In some ways, I have to apologize for being a psychologist because there's a lot of things that we've done in our field that have been very unhelpful. I was trained very early on not to actually talk to people about their hopes, about spirituality, around things that were actually important to them. And of course, I've learned in my work and community work not to do that, that it's actually important that I lift those things up. And so just to say, we want to thank you for showing up and for inviting us to be here. Tony, Deja, do you all want to say anything real quick?
Hi, I'm Tony Etheridge. I work with Dietra. I am a person in long-term recovery. I'm a peer support specialist for mental health and substance abuse. And I've been working with Dietra for the last 9 years, but I've been in recovery for the last 14 years. And I know that was it not for Dietra and giving me an opportunity to work and to do something meaningful and have recovery, then I wouldn't be here today and be able to share this space with you guys. So thank you for inviting us in, and we're just delighted to be here.
Hi, everybody. My name is Deja. I'm thankful to have joined the Both in Partners team very recently. It's maybe been 3 months now. And this is the most impactful work that I've been a part of. So I'm grateful to be here. I am the tech host, meeting host. So if there's any issues you have during this session, please feel free to shoot me a message. And yeah, I'm excited for this conversation.
Thank you. All right. So, anyone here familiar with Stephen Covey? All right, we gotta have. Did someone say no? Oh no, that's all right. That means like we're dating ourselves. Okay. So Stephen Covey, 7 Habits. Begin with the end in mind. This is just one of the pieces, but I do think it's helpful. So I definitely want to say that we'll leave room for question and response, and actually throughout try to create space for that. I think it's important that what we're focused on are some key things: compassion, a person's sense of dignity. In the recovery world, one of my favorite terms is the dignity of risk. And it's something as a psychologist, I think we often find ways to balance a little bit more. And in our world, we need to be able to balance a bit more. That growth only comes when you like have those things that you stretch toward, right? Always being person-centered, strengths-based, being very intentional with that. Um, I want to make sure that we are unpacking a little bit for you dominant culture and the antidotes, and essentially saying that recovery is one of those ways that we can be antidotal to that. We'll do a little bit of unpacking of what we mean by recovery in the medical model, or what is often referred to as a ROS. And then I wanted to talk about AI, and I had to make sure that I start to say appreciative inquiry because I've been talking about AI for probably 20 years, and only in the last few has AI meant something completely different than what I would normally talk about. So I've been doing a little bit better job of actually putting the two words in so that you know that I am not talking about a ChatGPT process. What we're actually talking about is starting off by looking not at the ditch, but at what we do have. And when I think about using an appreciative approach, it's important that I say that we are not talking about being toxically positive. Okay. I do a lot more to unpack what appreciative inquiry is, but I wanted to do this really quickly just to give you a bit of an overview that many of us sometimes get into these debates, right? Where we're like, no, it's 4, no, it's 3, no, it's 4, no, it's 3. And really, it's about perspective. And when you think about coming at it from a person's lived experience, we often need to just go to their side and find out what they're saying and understand from their perspective what that might mean. And that our systems have at times not always given us space to do that. Okay. That sometimes the way that our systems have been created make it so that it's difficult for us to get outside of our boxes and actually go see from that other person's perspective what is going on. And so, what I often have to do is that my team has always loved this set of slides to talk about appreciative inquiry. That what we're addressing is that most of us are used to fixing, right? Most of us are used to problem solving. I would say that if, I'm sort of in recovery as a problem solver, right? Like I got into this field because I was good at solving problems. And then when I started working with people, and maybe you have this even with your friends, right? You have the best solution for them. And what happens? They don't want to hear it. Anybody have that experience? Has anybody had that experience where you're okay, thank you. I need to no, I'm not alone on this. All right. So what we're doing and what I have learned is that what we have to do first is learn to embrace. Okay. So if I could do a dynamic slide here instead of just like the stationary slide, what I would do is I would have a big circle, two big circles, and what I would change is I would make the problem solving circle a little bit smaller, and I make this appreciative circle bigger, and I bring them in together. Because it doesn't mean that we don't ever use our problem solving skills. It's just to what degree do we use those problem solving skills? And how do we more focus on embracing by asking, well, what is actually making a difference here? What is giving you some sense of hope? Why did you show up today? What brought you to think that maybe something could be a little bit better in your life? And then, well, maybe we need to imagine what we might be able to do differently to then help us figure out what we should actually do, right? And actually co-create what we want to be doing together. And that is really the goal. All right. Anybody familiar with the research around our brain plasticity and fiction? Like someone? No, no one. Okay. So, one of the things that I like to point out is that one of the ways that we create more brain plasticity, so this means that we are able to imagine things outside of our day-to-day, is actually reading fiction. And that when we engage or have people who are willing to entertain other ideas, it makes it easier when you're working with other folks and you're expanding that you understand that that also helps your brain be more open. So some of the work that I like to reference is a book called Before Happiness by Sean Acorn, and just some ideas about how we as organizations can do little things to start to stretch and kind of move into this more positive psychology mindset. And so there are all kinds of different things, right? Activities that we know make a difference in creating sort of that brain plasticity and that openness and that ability to shift. So more gratitude in your life and those sorts of things. So that's like keeping a gratitude journal, right? Reading fiction, making sure that you're actually sleeping. We've also been understanding that, we're in sort of a epidemic, right, of loneliness in our culture. Our phones have us thinking that we're really connected and we actually are not. And that people need to have like that real connection with each other. And so we ask these questions because if you think about how you are trying to engage an individual or even your coworkers, if they're not getting good sleep, if you yourself are like not able to sort of balance and be fully present, then it's hard to take in difficult information. It's hard to have that capacity. And so one of the things that we always ask in the groups that we work with is just, how are you doing related to that? Oh, yes, Emergent Strat. This is one of my favorite books. Um, so absolutely, we have to be very aware of like how we are connecting with each other and then what the context is, and that all of that stuff actually has an impact and actually matters. So thank you for starting us off with that and just being aware of what some of those practices can be. What we probably didn't talk about is the importance of breathing. So what I'd like to do is invite us all to do 3 deep breaths together. All right. So get yourself centered. I'm getting myself centered. All right. Ideally get your feet planted on the ground, right? And just as together, and sometimes we even encourage, if you want to, you can come off mute so we can all breathe together, but you don't have to. All right, we're gonna take a deep breath in. Hold it. And let it out. All right, this is our second one. Take a deep breath in. Hold it. And let it out with a sigh. And our third one more time. Take a deep breath in. And hold it. And slowly let it out. All right. Thank you for taking that moment with me. I try to put these in my workshops. I encourage you to do that with yours as well. All of us tend to be breath holders, and so we just building it in as a reminder can be really helpful. All right. And it's also sort of anti our culture sometimes. All right, so another Stephen Covey, one of my favorite quotes that we need to be aware of is that most people do not listen with the intent to understand, right? They're listening with the intent to reply. So what I want us to think about is that it's important to both listen and believe. I've been told many times, Dr. Hawkins, I know you are trained as a psychologist and I know you know how to listen, but can you also believe me? When we think about the recovery community, one of the things that is most important is that we just believe people from the very beginning. And one of the ways that we can do that is to practice our dialogue skills. So I normally go into this much more deeply because we do workshops on facilitating change and leading sessions, but I wanted to just give you a quick visual that most of us are in a space in which we're trying to serve or learn, which means that we should be doing more dialogue. Most of us are not in a space in which we're trying to convince or win. That is when you use the skills of debate. Many of us live in a culture in which people use these words as if they're the same. Okay. If you are tracking with me, would you put a 2 in the chat. All right, so most of us are still here. As we do this work, I think it's important that when you are trying to help people be in a space of cooperation, right, then we need to actually invite and teach people the skills of dialogue. But if we are trying to be in competition, then that would be a skill of debate. And so very often, one of the things that happens is that we need to like just highlight that for people, that that's what we're doing. We're asking, what did we notice? What came up with that? These are so, so very important. And I love that. So if you're familiar with this image, this is the image of the elephant, right? And the men with blindfolds, the blind men, you could say, and they all have a part, you know, and what we want to be doing, and the reason I brought this up is that I think so often in our work, we feel like we're alone and we have a piece of what's going on. And part of what I hear everybody talk about or complain about is communication. You know, how do we work together? How are we sharing together so we can all learn that actually we just have a piece of the elephant and that it's not, you know, the wall, the rope, the tree, you know, and all these different things. Um, and so although I'm talking about medical model versus recovery model, that's what's there, I really see these as going together, because I'm not in a place where I think you get rid of something. It's really just understanding where it's best positioned. So overall, when we think about the medical model, these are the assumptions that are, you know, sort of key to be paying attention to that tend to get in the way. That what we tend to understand from a medical model perspective is that we're reducing things down to a disease or illness and disability, right? That there tends to be a sense of reliance on medication. This is where people often push back on you, right? They're like, I don't want to just be medicated. Then you have another group of people, can't you just give me a pill, right? Um, and this is, you know, again, this is where I'm always in trying to help us get outside of looking for the right thing, which is also a very dominant mindset. We got to find the best thing, the right thing, the one thing that's going to make a difference. And yet, for most of us, we need many things, right? It's not just one thing. So I want to pull a few of these apart a little bit more. So some of the assumptions that really gets in the way is this idea about being fixed or cured and really focused on deficits. And I think we've already established that what people want first is not to be seen as broken. Okay. What people want is to be seen as having some capability first, and then they want to be able to talk about the things that get in the way. Okay. Another piece that can get in the way in terms of an assumption is that our medical models have overemphasized that the person's illness is what is preventing them from being normal. Okay. And then what that ends up doing is that caregivers and professionals are making decisions for people. And then we're getting mad when they're not following the things we told them to do. Okay. So we're actually setting all of ourselves up. This is why I want to like kind of focus on this because like it sets us all up, right? Because we're gonna go over here and come up with this plan that they weren't really involved in, and then we're mad because they're not following the plan, but it didn't really involve, you know, wasn't like really taking into account what was going on in their lives. And oftentimes it can be very small things that will make the biggest difference. So the next piece of this that we want to really get to, that becomes very sad, I think, is that the person can become an object of charity, right? and can only be seen as something or someone that needs to be helped as a receiver of help, that they don't also have gifts to offer, that they don't also have family members that are counting on them, right? That they are not a full person, that exist. And so we need to like be aware of how that can happen, right? And that the other place that can get in the way is that sometimes we get into this place in which they need to fit into society, instead of understanding that there are things that we in our culture can do to support others. Okay, so very few of us right now are aware of all of the various tools that we use. I mean, I think about the closed caption that's available. I rarely watch TV without closed caption myself now. You know, there are just a lot of things that we actually all need at some point, and we don't always think of that as being a deficit, right? So, as we move in this direction, what I wanted to remind us of is that we can all breathe. So, we're going to take a deep breath in and we're going to let it out. Sometimes when we talk about medical model things and like where we get stuck, it can feel really yucky and it can feel like there isn't anything we can do. And what I want you to know is that systems are people and there's always something we can do. So, my work for many years has been in supporting what we call recovery-oriented systems of care. Is this a term that's familiar to people? Can I get a yay, a hands up? Anybody that this is a new term for? Put like a 4 in the chat if this is a new term. Okay, there we go. Yeah, new, old, sort of in between. Um, So some people might be more familiar in the children's system of the, sort of because it was really based in the children's system initially. But I think it's always important when I start talking about a Ross that we acknowledge what it is not. Okay. So it is not just about a model because we're going to get into why that is in a minute. It is not primarily thinking about just recovery support services. So many organizations, when they think about doing a Ross, they think about just implementing recovery support services. It is also not dependent on new funding. Many of the systems that I worked with in the past have done a lot better with like less money and more about the coordinating care. So creating and using what we call more of a collective impact approach, where you're actually leveraging among each other what you already do well. And so you're not replicating and like repeating things over and over again. We're not talking about something that's new. Are y'all still with me? I just saw one of those notices that it's low system. Okay. um, we're not talking about just a group of providers or the infusion of evidence-based practices. I come from the world, and when we think about lived experience, living experience, that oftentimes that has not been considered evidence-based, but it's actually practice-based, right? It's about that person's own experience. And it's not just a closed network of services. What we are talking about is essentially a values-driven approach. Okay. And it's a framework that's going to be rooted in understanding what is recovery and what supports a person having a life that is meaningful, that we understand that recovery is real, that we are asking people questions like this. What is right with you? Anyone start off asking people this question? There's actually a book by Barry Duncan that talks about this. What could be better? What has helped you come back from something difficult? So we want to do another breakout. And this is a chance to practice answering this question. What has helped you come back from something difficult? The trick with this is that you want to tell a story about what helped and not just tell the story about the things that were difficult. Okay. So I just to say, like very quickly, um, I had 5 surgeries in 10 years. And the thing that helped the most for me was actually being able to talk about post recovery and not just the surgery. It was the communities that helped me laugh, that helped me get active again, that helped me remember that there's a way to be like, there would be a future beyond the pain, all kinds of other different things. And it was also a community that came around and supported me in ways that I never knew that I was going to need, right? Not being able to do your own laundry, not being able to like pick yourself up, opening your eyes when you stand up and you're in pain and you don't want to, to see. So as when I think about what has helped me, it has always been that community and information and like actually post the crisis that was really critical. Well, I want to just say first, thank you for being with us in this. I'm sure some people may have to hop off a little bit early, but thank you for joining those breakouts and sharing your stories about what has helped you. Um, I want to just highlight for you that this is a question that we have used um, all over the country and all over the world, actually, to help people create systems of care. Okay. And what we find is that there tends to be this big list of like things that help people. So looking through this list, do you see any that resonate from what you all shared? Okay. And there can be more. You can see that I've got some that are kind of starred, but finding ways to help others. What I didn't put in here, but I do hear many times is like pets, purpose, finding a way to like give back. Like that is like just huge. There's like a whole nother list of things that really becomes helpful. What I love about being able to ask this question is that you don't have to identify as having a mental health or substance use history to have had something that has helped you come back from something difficult. Okay. Which means that as we create systems of care or our support systems, what we want to do is make sure that whatever we're creating helps us have these things, right? Helps us understand the importance of family that is supportive, even if it's your chosen family, helps us to find ways to give ourselves time or to get education or to see others who've been there before. In a series of interviews and focus groups we did, this is one of the quotes that came. Can I get someone who'd be willing to read this for the group?
I can read it.
Thank you, Karen.
Recovery is not simply about personal health, but the health and well-being of the entire community. This isn't about me. I'm doing this for my children and my community. I have to build up my community because I need to know that if something happens to me, there will be resources and people in the community who can step in and take care of my girls. A mere participant.
So a program I worked with, thank you so much, was African American Men in Recovery. That's what AMIR stood for. And this is one of my favorite quotes that came from some interviews we did with them about why recovery was important to them and what it actually meant to them. That it wasn't just about their own personal journey, but it was about a community journey. And so when we start to think about the medical model, sometimes our medical models just reduce things to like symptoms and don't necessarily incorporate people and communities and the other resources that are important. And so from a recovery perspective, we want to recognize that there are many pathways, right? Some of that might be mutual support. Some of that might be professional treatment. Some of that is often faith-based programs. I work with an organization so the Yale Program for Recovery and Community Health. We have a program that Dr. Sherelle Bellamy has supported, which is called Imani. And so it's a faith-based recovery program. And it's just been amazing to see the way that that has like supported people in their own journeys. We know that medicated assisted treatment is important. We know that there is such thing as natural recovery, and that my favorite thing to think about is that there should be no wrong door. Okay. There should be no wrong door for someone coming in when they're asking for help. So we like to try to simplify that what recovery is what a person does. It's about having a meaningful life, and it's really what we all want. How does this then connect? My mentor, Larry Davidson, would say this, right? That traditionally, as professionals, we've treated substance use and mental illness with the hope that the addiction or the mental illness would go away. But often what was happening is that we sent that person away. Now we're focusing on preparing and equipping people to take care of their addiction or mental health themselves while remaining in the community. This is a paradigm shift, and it's one we're still in. And so as we think about dominant culture has a tendency to say that we only, the squeaky wheel gets the oil. Anybody heard that before? Anybody seen that in your settings? Okay. Um, where sometimes you see a lot of defensiveness and denial. Um, some really interesting things that, part of certain diagnoses is actually denial. And so we end up like punishing someone for confirming their diagnosis. This is what we want to like find a way to make a flip around. Um, in our dominant culture, there's a whole lot of other things we can get into related to that. One of the things that I see, especially in our healthcare settings, is that productivity ends up being prioritized over the relationships. And we just heard, right, how important it is to have that relationship, to make that time, to make that connection. And especially when we're talking about issues related to mental health, addiction, or just being well. So we want to find ways to work against perfectionism, talking to people about doing things that are either or, not finding ways. This is one of my favorites, which is understanding risk management versus the dignity of risk. So one of the ways this shows up is, let's say that a person's, we're setting someone's goals. A goal would not be abstinence, for example. A goal would be being well and having their kids back. Like that's a more like personal goal of what someone is actually going to set. But what will happen is that someone will say, well, that is very risky. Well, we want to be able to have the conversation with someone about what do they need to actually like have their children back in their lives. That's what we balance in this work and what it means to be more recovery focused and the antidote to the work that we're trying to do. So, what I like to recognize is how it shows up in our systems, right? Where sometimes our goals are very transactional versus being transformative, where there can be a sense of everything that's important is only if it's crisis driven. This is the one that we see, ooh, way too much. Overworking is the norm. Okay. The only time it's real is if it's written, right? And that we tend to do a lot of root cause analysis. Okay. What can we do? What we can do is we can dig deeper. Okay. What we can do is what we can focus on being recovery focused. And I have a whole list of things, right? Finding ways to pilot and celebrate small wins, finding ways to find a balance between both intellect and emotions. So in our diagnoses, sometimes we tend to, especially culturally, we're not very good about balancing whether or not someone's emotions, like how they are expressing themselves, and then how they talk about that, how those things go together. And that is very indicative sometimes of the diagnosis that that person has. So we should be much more aware and sensitive to what those things are. Cool things, finding ways to listen deeply, understand somatic wisdom, like how a person actually feels in their bodies. We like to encourage a both and approach, right? Embracing a growth mindset, thinking about healthy competition instead of like a win-lose competition. We can actually work toward win-win, and creating partnerships. So power with as a model. Some additional antidotes, where we value both information and relationships. We find ways to be holistic. We look for those multiple pathways forward, and we practice shared decision making. I think that that shared decision making is not just with the individual, but also across disciplines. In our work, we can find ways to support both individualized and community supports. We can find ways to normalize mistakes, right? All of us have done something, but we shouldn't be penalized for that one worst mistake we've ever had in our lives. We want to find ways to decenter expertise and really lift up a person's own lived experience and the community's lived experience and being strengths-based. And finally, we want to remember to breathe. Yeah, so thank you, Deja, for putting that in there. Definitely follow up with us. There are a number of resources and also support that we try to offer people to like talk through this, do this with communities. Some of our favorite work has actually been engaging communities in the conversations, because that's, there's a lot of stigma, right? There's a lot of fear. And most people haven't had a chance to talk about the things that have gotten in the way. So it's hard for them to like have an idea of hope because they're still just in that trauma, right? They're still just in that other space. So that's one of the things that we often, try to help people with. Yeah.
That's wonderful. Thank you, Dr. Hawkins.
Absolutely. I know you all have some slides.
We have just some slides coming that give us, I don't know if we can go back to the deck at all.
Here we go.
Just to share with the group, I know we have a QR code on one of the slides. So we wanted to just give you an update on Northeast Ohio Opioid Consortium information. So we have the Consortium Chronicle, which is our monthly newsletter. We're going to try to start sending that mid-month instead of the end of the month. It just seemed like timing of some of the announcements, it would work better. So we're going to give that a try. If you don't currently get the newsletter, please use the QR code or go to our website and you can sign up. If you haven't received the newsletter, the past issues of the newsletter are there. In this newsletter, we talk about local as well as statewide initiatives and national policy initiatives. And then we highlight research and training opportunities as well. So it's sort of a catch-all. It's a service to the community to support the great work that's going on in the community. If you have something you'd like us to include in the Chronicle for the community, please send those to us. And we would be glad to include those. So that is our Chronicle. Next slide, please. We have a couple of other updates. Rachel, are you able to talk about our chronic pain management work?
Yeah, so for those of you who might not be aware, we have been meeting as a small working group. Actually, some of the folks that are part of the working group are on this call, but we have been doing a series of focus groups with people with lived experience who use opioids to manage chronic pain, and a lot of similar feelings and experiences and reflections on their care and treatment that we've discussed here today are also present in those conversations. And so we are at the point of drafting our report on those findings, and we'll be working together with that group and the folks who participated in those to be thinking about next steps. So that'll likely be shared in our consortium chronicle. So please keep an eye out for that. But just, I'm really passionate about that group. It is a group of people that maybe don't get the same kind of attention or focus that the other other areas are getting right now. So we're excited about that work. In our next series, we'll have March 20th, medication-assisted approaches to treating opioid and substance use disorders. So we will be joined by Doctors Elena Yanchar and Dr. Dorothy Rimelin from the centers. If you're local, you might be familiar with them. So we're excited to have them. And then we're working on our final speakers for this year. So we'll keep you posted as we get our things confirmed for May 8th and July. Thank you.
Right. We posted the feedback form. Your feedback, it says your feedback is very important to us. If you could fill that out, or at least we would love to have your feedback. We get evaluated as part of our CDC OD2A local grant, and this consortium series is part of that work. And so we value and we really need your input on the topics that we talked about today, future topics you'd like to see. So if you wouldn't mind taking a few minutes or copying the link and coming back to it later if you have to run, we would love your feedback. Thank you, Natalie. I am so glad I've received a bunch of positive about today's session. Thank you, Dr. Hawkins, to Tony, and to your team. We appreciate that we had this opportunity to partner with you. And I think this was a great way to start off the year with our education series, and a lot of reflection. So I appreciate the seeds that you've planted.